Ma però sono quello del computer. Ok. Qua tre. Quindi abbiamo Possiamo anche cominciare, please let me introduce you in Italian Welcome to everyone. Buongiorno, benvenuti a tutti, agli studenti, ai colleghi. Oggi sono particolarmente emozionato perché questa giornata vede come ospite una prestigiosa ospite, scienziata e amica che viene dall'Università di Filadelfia, la professoressa Elizabeth Mauldin, che è professore di patologia veterinaria presso appunto la Facoltà di Medicina Veterinaria di Filadelfia, è il direttore preside diciamo, del laboratorio di patologia veterinaria e tossicologia, e è una dermatopatologa famosa in tutto il mondo, double boarded con 2 diplomi di college, è diplomata al college americano di patologi veterinari e anche al college americano di dermatologia veterinaria, è membro di molte commissioni e è una delle più importanti esponenti del mondo della dermatopatologia, non solo della patologia veterinaria, per cui abbiamo insomma il privilegio di averla qui e di sentire i suoi insegnamenti, per cui è un'opportunità unica. Thank you to come, you are very welcome. And thank you to Charles Lewis Davis Foundation. I would like to say welcome to all members of Charles Lewis Davis Foundation and ACVP, ASVP that are in live streaming in this time. And you're very welcome and thank you to come again. And please, you can start. Grazie. Grazie a tutti. Microphone.
It's no, the microphone should be here, correct?
Okay. No.
Ah.
Yeah.
Grazie mille, professor Leonardo. Piacere essere qui. Dimmi se non capiti. Parlerò più lentamente. Mi dispiace, non parlo italiano bene. Adesso parlo inglese. Thank you. I'm very happy to be here. Sorry for the mistakes in Italian. I'm trying. Sto provando a imparare italiano. Very hard. Okay, so let's get started. So the purpose of this lecture is to review some recent advances in veterinary dermatology. What I've found as a veterinary pathologist is it's hard to keep up with the dermatology literature. For one, problem is in the United States that the main publication in veterinary dermatology, the journal Veterinary Dermatology, is not required material for the exam. And many veterinary schools no longer have dermatologists, full-time dermatologists. So I worry that our students and our pathology residents in training are not educated enough. So I'm just going to update you on some current diseases in veterinary dermatology, as well as include some newly recognized disorders. And the purpose of this lecture is to improve your skill set and expand your differential diagnoses. So the basics, our purpose is to develop a knowledge base, and we're going to review some of the basics of skin anatomy, and I'm going to give you a reason why. So this is a true story. This is Monday morning in October 2016. And I'm sitting at my desk. When I read biopsies, I'm sorry, I have to stand here. When I read biopsies, I start by looking at the slide before looking at the history. And I'm examining this case, and the lesions that I see are infundibular keratosis that extends into the secondary follicles, is producing these small comedones. I'm like, okay, this animal has comedones and maybe some hair loss. And then I look at the history, and the history says that this is an 8-year-old female spayed cat that recently moved from New York to Florida. And the cat has scales and crust on the head. That's my complete history. So I look at my slide again. It just doesn't fit, okay? And particularly, I'm looking at these sebaceous glands, and they're really messy, flayed out. And that's not typical of a cat biopsy. I'm thinking this is a very strange looking cat. And for your pathology residents, this is a very important skill set for you to have. Simple species identification without history is very important because it includes a last step of quality control. Because as the tissue comes from through your laboratory, you cannot control every step. But the last step before you issue the report, you can have your own quality control. And this is the typical sebaceous glands of a cat. And I described them as being very neat and fastidious like cats, and they're tightly oriented to the adnexal unit. And this is a dog where the sebocytes have vacuoles that are unevenly sized. And then my biopsy that's supposedly from a cat, it looks more like a dog. So I go back to the lab and I check the jar. The name, everything matches. I go to the technician who's trimming the sample. It goes through the processing and embedding, and in every step, your technician can make an error of mixing up tissue. It all seems to fit. So requisition number, sample jar, the correct number of samples, everything matches. So then Tuesday morning, we received a biopsy with the same submission form, an 8-year-old cat that recently moved from New York to Florida. And this was the biopsy from that cat. And this is for your third-year residents, second-year residents. This should be very easy for you. For your veterinary students, what you're looking at is a hair follicle. This is the outer root sheath. This is the hair shaft, which contains fungal hyphae and spores. So this is dermatophytosis. So the clinician sent us the wrong report, the wrong submission form. And so what this case was actually was from a 5-year-old Chesapeake Bay Retriever with alopecia and scaling. And so this is what this animal should look like based on my initial biopsy. I should have hair loss, and the Chesapeake Bay Retrievers have hair loss. This is acquired, and we don't know why, in the axilla and in the caudal thighs and along the thorax. And the histopathology looks very similar to cyclic flank alopecia. The notable difference is you develop these pink-looking hair shafts that are degenerate. And also you can have signs of pattern alopecia on the caudal thighs. It's a little bit different from cyclic flank alopecia because of the change in pigment, but that would be an a good differential diagnosis. And one of your colleagues is the who wrote this manuscript, Rosario Cherundolo, who is now in the UK. So the purpose of this was just showing how just your everyday skill set can help you with quality control and make sure that you did not call that cat a weird form of alopecia when it actually had dermatophytosis. So for those of you who are just starting, just starting in dermatopathology, I urge you to look at the H&E blinded to the history. When you look at a skin biopsy, you're going to treat it just as you would a kidney biopsy, where you're going to look at every single structure in the skin systematically. Know your breed and species differences. So if I examine a biopsy from a husky dog, it would look dramatically different than normal skin from a husky from a standard poodle. And what's important for us as pathologists is to know the gross lesions for the disease that is suspected. And in dermatology, you must know the gross lesions. The dermatologists tend to be better gross pathologists than we are as pathologists. So I'm not going to belabor the perivascular dermatitis. I think that is inherent in our training, but I'm going to systematically point out some changes that have happened in the diagnosis of perivascular dermatitis over the past few years. For those of you who are just studying pathology, pattern diagnosis is a form of generating differential diagnoses on low power. And this categorization was developed by Bernard Ackerman in the late 70s. And he was treating medical doctors on how to recognize dermatologic diseases under the microscope. And I'm going to go through these slowly as we go along, but I won't belabor them at this point. So when I encounter a difficult case, I don't try to rush through it. I put it aside for a day and I ask my colleagues. If I try to rush through it, then I am more likely to make a mistake. So let's talk about some changes in DermPath right now. First, we're going to talk about very briefly, and this is for the residents, on how to correctly perform a skin biopsy, and the students, because those of you who are studying in vet school are going to be doing skin biopsies when you finish. So the skin biopsy is used very commonly in veterinary medicine, and probably much more commonly than it would be in human medicine. When you're doing a skin biopsy, it's very important that your client understands the limitations. For instance, if I perform a biopsy on an animal with a tumor, let's say I take 10 animals that have tumors, and I biopsy those 10 animals. Of those 10 cases, a pathologist is going to give a definitive diagnosis in 9 or 10, right? You're at least going to get it in a round cell tumor, a mesenchymal tumor, epithelial tumor. But if you're doing skin biopsies from 10 dogs with inflammatory skin disease, you may have a definitive diagnosis in 4 of those cases, right? 4 out of the 10. And so you have 6 cases where you're going to give a morphologic diagnosis. And so in referral practice in the United States, that biopsy procedure may cost $800 or $900. So it's your job to educate the client that when you're doing skin biopsies, it's not just for the name of the disease, but to give direction. You know, you don't tell your client, we're going to biopsy this because we want an answer. You're biopsying it for many different reasons. So this is a big mistake that people still make. And I'm sure Kiara recognizes this immediately. This is a biopsy taken with laser or electrocautery. People still do it. You can't do it. It burns the tissue. The reasons that clinicians submit biopsies, number one is because the disease they suspect can be diagnosed by a skin biopsy. And this is a case of sebaceous adenitis in an Akita, and the only way to get a definitive diagnosis is by a biopsy. This is, I love to include this slide because this is a dog that has been on cyclosporin, and cyclosporin causes gingival hyperplasia, but occasionally you will see nasal planum hyperkeratosis, and we call this dog a unicorn. So sometimes the clinicians just want to understand more about the disease process. In my country, it's important to biopsy cases for legal documentation. So this is a cat with pemphigus foliaceus. Your differential diagnosis is dermatophytosis. It's classic pemphigus foliaceus in a cat because there's crusting on the on the face, and on the ears. Crusting, not scaling. Classic pemphigus foliaceus. You may see acantholytic cells on cytology, but and so you may know what it is, but in some cases you want a biopsy to absolutely confirm it and have it written on a piece of paper that this is pemphigus foliaceus. Many dermatologists, and particularly some of my dermatology residents, will biopsy an animal when they become lost. They're treating a dog for 9 months for superficial pyoderma and it's not responding. So it's not responding to rational therapy. And we also biopsy for severe clinical presentations. So everyone in the audience should know this is a cat with eosinophilic granuloma complex, right? Rodent ulcer. Sometimes if these don't respond to therapy, you want to rule out squamous cell carcinoma. This is a cat with sporotrichosis, and this is just an atopic dog that failed to respond to therapy. When you're educating your clients on how to biopsy, particularly if they are young and just out of school, it's best to biopsy the full spectrum of lesions. Sometimes we tell our students to biopsy primary lesions. A primary lesion would be a pustule, a secondary lesion would be a crust. But when you have an animal on the table, the consultation table, and you're examining it, sometimes these primary and secondary get all confusing and they blend together. So just biopsy the full spectrum of lesions. And you usually do not need your veterinarian to biopsy normal skin. Kiara is very experienced in looking at normal skin. Don't waste the biopsy on normal skin. Just give her affected skin, correct? She only wants affected skin, unless it's a weird alopecia case. And you want to biopsy the full spectrum of lesions. And in each lesion, let's say we have a pustule, it starts as a papule, and then it becomes fully developed, and later on it is a crust. And it depends on when you biopsy as to what the yield will be. This is a dog with an acute thermal burn due to, it's due to lighter fluid on the head. Yeah, some mean persons sprayed lighter fluid on the head. And it was ignited. So if I biopsy this dog at this point in time, it would look like a thermal burn. But if I wait 2 weeks later, my biopsy just shows severe dermal fibrosis and scarring. Another thing to consider if you're biopsying panicular lesions, so lesions in the subcutaneous fat, consider doing an excisional biopsy because sometimes the punch biopsy is going to miss your diagnostic material. You will find some dermatologists will do a double punch. They'll punch the surface and then they'll take the punch and they'll punch the deeper tissue. That works as well. In practice, send 3 to 4 samples. Any more than that is probably too much. And you increase the price without increasing the yield. Always use a 6 to 8 millimeter punch biopsy except for the nasal planum and the paw pads, and then you can use a 4 millimeter. There's a great amount of difference between the 6 millimeter and the 3 millimeter punch biopsy in this diagram. Look at the difference in the adnexal units you can obtain with a 6 millimeter versus a 3 millimeter biopsy. Don't scale the biopsy to the size of the animal. I've had some clinicians, when they biopsy a horse, they give me these big samples, a dog or smaller samples, and they biopsy a cat. I get 2 millimeter biopsies. Don't do that. Cats can have 6 millimeter biopsies. It's fine. As a pathologist, you should absolutely demand a signalment, a brief history, including medications. You don't need a copy of the medical record. You need to know the location. It's very important that you know the clinician describes the lesion, and it's also very important that the clinician tells you what disease they suspect. And this is always a problem for us because we occasionally get biopsies that don't even say dog. They say skin. Right here, they just say skin, if we're lucky. The most important thing to do when you're biopsying the skin is, number one, we don't scrub the punch biopsy. I think you guys all know that. the lidocaine must go in the subcutis instead of the dermis. If you put it in the dermis for the pathologist, it will look like dermal edema. And this is a punch biopsy from the paw pad of a cat. And what is most important that you do is that when you take this punch biopsy, you use the cutting of the tool and you don't touch the sides. When you take it out, it doesn't matter how you get it out of the skin, just absolutely do not touch the sides. When you touch the sides, then you crush it. Common mistakes are poor site selection, scrubbing of the site so there's no crust in the sample, not enough tissue, poor sample handling, and I don't know if this happens here in Italy, but we have cold sterile bins, cold sterile. So we have like a chlorhexidine, something like that, and the clinicians put their instruments in it. And sometimes they try to reuse the punch biopsy. That's not good. They end up being dull, and also it doesn't properly clean them. So use a new punch biopsy for each patient. And sometimes, I'll show you, if I have a picture, that is too slow to go into formalin. In my country, in the winter, we have a big problem with freeze-thaw artifact. And when the biopsies are mailed, if they're not already formalin fixed, they can freeze. And it's a real problem for interpretation. And the last thing I want to show you about using a punch biopsy is sampling marginal tissue. So this is a dog with an English bulldog, and you third-year residents should know this disease, do you? This is cyclic flank alopecia, right? Or canine recurrent flank alopecia. When I see it, to me it looks like, I call this geographical alopecia because it looks a little like New Zealand or Africa, right? So it's pigmentation and hair loss. It's cosmetic, only cosmetic. But watch what happens if you take a punch biopsy from the margin of this tissue. And this is what we train students to do, because if you think of if you're biopsying a spleen with a nodule in the middle, right? Hemangiosarcoma, let's say, a spleen, a nodule in the middle. What happens if you go in the middle? You just get necrotic tissue, so you have to go on the edge. But that's not true in punch biopsies. So if you look at this diagram, this is where the punch was taken. And now the punch is going to go into the laboratory, and the technician is going to cut it down the middle. And in this case, this is the affected tissue. This is the side that is cut. So dermatologists that are taking marginal tissue can sometimes completely miss the lesion. What works better, in some cases, particularly ulcers, is a ellipse, where you take, you use a surgical sample and you orient it in the direction of the hair. Also be careful using punch biopsies for vesicular lesions, because you can completely lose the epidermis. This is a case of bullous pemphigoid in a horse, and the epidermis is peeled off. Finally, when you're biopsying for alopecia, so the animal has no hair, it's often helpful, instead of marking your site for anesthesia with a circle, is do it in a line. And the clinician biopsies over the line and is cut on the line. And so you see a beautiful orientation from the hair follicle. Instead of a cross section, you have a nice longitudinal section. That's called the line technique. It's really easy. And this is the image showing the cutting along the flow of the hair and just beautiful orientation of the hair follicles in longitudinal. This is a standard poodle, has many anagen growing phase hair follicles. This is a case of a West Highland White Terrier, and the clinician was performing the biopsy. He put the sample under the light while he sewed up the animal. He sutured the animal, and during the 10 minutes it was under the light and underwent desiccation, and it made it uninterpretable. And this is another sample with electrocautery or laser. All right, that was just a brief review of how to perform a skin biopsy. So let's talk about more derm path issues. So this is a dog, a classic atopic dog, And you should see clinically it has oral ear erythema and a little bit of erythema around the mouth. So we're going to talk about allergy for just a few minutes. So for your pathologists out there, allergy is a clinical diagnosis. Occasionally you will have someone who submits a biopsy to you who wants to know what kind of allergy it is. You can't do it. All you can do with your pathology is support the clinician's diagnosis. So this was a landmark publication in 1999, and a task force organized by Thierry Olivry reviewed all the literature on veterinary allergy. And this is when the term allergic inhalant dermatitis was evicted from the dermatology literature. And it was found that dogs were more likely to be sensitized through the skin. Although they may be sensitized by food, by eating the allergens and inhaling through the skin, this epicutaneous was the major route. Also, a term that's not used anymore is food allergy, although I still use it, but now the new term is cutaneous adverse food reaction, because you don't know if it's in many cases, if it's a true hypersensitivity or if it's a different type of just food intolerance. What has really changed in the literature in both human and veterinary dermatology is, again, looking at the skin barrier as a part of the pathogenesis of allergic dermatitis. And this publication is by my mentor in the human literature, Peter Elias, and then Rosanna Marsala has done a lot of work on the skin barrier in atopic dogs. So atopic skin disease is diagnosed by clinical criteria that was initially proposed by Willemse, and then Dr. Prelog in 2010 did a great publication that showed that you cannot tell clinically the difference between food-induced atopic dermatitis and non-food-induced atopic dermatitis. So I can't examine a dog and look at it and say, oh, because it has anal lesions, it's more likely to be food-induced. This paper dispelled that. It is the dermatologic workup that tells you if it's food-induced or non-food-induced. This is our classic atopic dog with flexural fold lesions and lesions on the distal limb with lichenification and hyperpigmentation. So why would a veterinarian perform a biopsy on an atopic dog? Number one, they may not be a very good veterinarian, right? They may not have a lot of experience in dermatologic diseases. This could be a dog that had poor response to rational therapy. It could be an unusually severe manifestation, and they want to know if they're missing something. So it's our job as a pathologist, we are just merely confirming or refuting the clinical diagnosis. And the histologic features of atopic dermatitis, it is a hyperplastic perivascular reaction pattern with spongiosis. The important things in canine, not feline, but in canine atopic dermatitis is eosinophils are only a few. You would think that it's a type 1 hypersensitivity reaction that you would see many eosinophils, but you don't. You see few to rare eosinophils. Another feature, if you look for, you may find small aggregates of round cells, Langerhans type cells in the epidermis, and you may find small aggregates of eosinophils in the epidermis. But those are the classic features of canine atopic dermatitis. And this is a great case. So what I like my pathology residents to do is to look at the histopath and imagine what the animal would look like. And with this degree of epidermal hyperplasia, this is a biopsy from lichenified hyperpigmented skin. And our features are epidermal hyperplasia or acanthosis with spongiosis. It's a little perivascular inflammatory infiltrate. And this has parakeratotic hyperkeratosis, which means retained nuclei in the stratum corneum. That's okay. You can get that with allergic skin disease, and it's multifocal. So if there are histologic features of atopic dermatitis, why can't you achieve a definitive diagnosis on histopathology? It's not going forward. There we go. Okay, so this is a skin from an animal that has a hyperplastic spongiotic reaction pattern. There are a few neutrophils and eosinophils in the dermis. It certainly could be allergic. But if you look at the bigger picture, this is a subcorneal pustule with acantholytic cells and actually in rafts. So if your clinician has scrubbed the biopsy, the dermis can look just like an epidermis, can look exactly like an atopic animal. So the whole biopsy has to be interpreted with the clinical presentation of the animal. So, and I've had many cases, particularly in cats, where they're diagnosed as allergic, but it's because the biopsy was not very good, or the pathologist missed the acantholytic cells. Now, no one in here would miss these acantholytic cells. This is classic pemphigus foliaceus. So another case, this is a hyperplastic spongiotic reaction pattern, but with marked parakeratotic hyperkeratosis forming these spires. Some people call them church spires or follicular spires. So this lesion is diagnostic for zinc-responsive dermatosis, but if the clinician scrubs the biopsy and you don't have these parakeratotic caps, it's going to look just like atopic dermatitis. And in that case, what you want to know, you need to know the clinic. You'll know it's a husky or an Arctic breed dog, and to know that the clinical presentation are areas of hyperkeratosis around the face, then you won't make the mistake of calling it allergic. So it's important to know the gross lesions. So look at the difference between these two gross lesions. So this dog, this is all due to self-trauma. This is alopecia due to rubbing. This is an atopic dog. It has otitis as well. However, this dog has more crusted lesions. So this is typical of pemphigus foliaceus. Finally, so when allergy is going to be the most common diagnosis, right, of all our pets, allergy is going to be the most common diagnosis. But as a pathologist, don't use allergy as your default. If you don't know what it is, you don't know what it is, but don't always say it's allergy. There are many non-atopic dermatitis allergies, non-atopic dermatitis reactions that can mimic atopy. If your biopsy is massively eosinophilic, many eosinophils, then it's not likely to be canine atopic dermatitis. You want to think of a type 1 hypersensitivity reaction to something else, insect bites, adverse drug reaction, or ectoparasitism. So do you see this here in Italy?
We have
Sufficiently. So this, I don't know why, but this disease is very common in the United States, and it seems to be getting more common. And the clinical presentation is a dog with vomiting and diarrhea. It's treated for vomiting and diarrhea, and then it develops red macules, papules, and plaques on the abdomen. Or it can be just a diffusely red, diffuse erythroderma. Histologically, it's a little boring. What you see in most cases, superficial dermal edema with a mild perivascular or interstitial, a mild inflammatory infiltrate. But you have a band of edema and a relatively mild inflammation. There should be eosinophils in the inflammation, but sometimes they've degranulated, so we use a Luna stain to see them. And this is a Luna stain where I can't tell that these are actually eosinophils, but the little pink bodies are staining eosinophil granules. So this is eosinophilic dermatitis with edema. It's a disease of dogs. Most have a history of vomiting and diarrhea, and you have a rash that occurs 1 to 2 days later. Almost all the dogs have been treated with many different drugs for the vomiting and diarrhea. So finding the drug, if there is a drug that caused it, can be difficult. And we initially reported this scenario, I think it was back in 2006 or 2007. And some of our cases had vomiting and diarrhea. And then more recently, we associated these cases and characterized the gastrointestinal disease a little bit better. And what we found for the pathologists in the room is that it's not always this pattern. This is a relatively mild pattern, which we call type 1 with mild inflammation. Sometimes it can be more severe and you can have eosinophilic flake figures. And this occupies the mid-dermis, but sometimes it can be diffuse and spongiotic with spongiotic vesicles. And any three of these patterns correspond with the same clinical presentation. There was no difference, and it didn't predict drug exposure or anything. But the point of this is that it doesn't all look like the relatively mild inflammation. Some of them can be actually very severe. So I've been trying to name this because it was initially named for Professor Wells in the human literature, and that disease doesn't fit. So we're calling it canine acute eosinophilic dermatitis with edema, and it is vomiting diarrhea. These animals have hypoproteinemia. The skin lesions occur during or following treatment of the vomiting and diarrhea. In the drug scoring method, some may have an adverse drug reaction. There are 3 histologic patterns, but the histopathology is not predictive of the outcome or the cause. So another disease that's not canine atopic dermatitis, but can mimic it, is this disorder in dogs, and they present with an acute onset of lesions on the muzzle, not localized to the muzzle, but usually on the muzzle. And they're red and they can be itchy. Histologically, there is severe folliculitis that is eosinophilic. And you have necrosis of the outer root sheath with tremendous dermal inflammation and edema. So eosinophilic folliculitis and furunculosis, typically associated with insect bite reactions. They can occur any time of the year. In fact, I think I see them more commonly in the winter. I don't know why. This is a true case that I had a few years ago that was unusually severe on the muzzle. And it was severe eosinophilic folliculitis and furunculosis with ulcers and hemorrhagic crust. And so I contacted the veterinarian, and they found this in the house. I don't know. They sent me this picture. Is this what did it? It beats me. I don't know, but I think it's kind of funny anyway. And the dog healed up just fine. Any questions on allergy? Okay, a little review on pustular dermatitis. So this again is your classic picture of pemphigus foliaceus, a subcorneal pustule with acantholytic cells. These are organized into rafts and neutrophils, non-degenerate neutrophils. And our dog again with pemphigus foliaceus, you want to know you're looking for an animal with crusted or pustular lesions. But then a few years ago, we started seeing a different pattern of pemphigus foliaceus. And this is when lesions occurred on the dorsum rather than on the face. It's your classic pemphigus foliaceus in a chow. So let me say that again. I kind of got myself mixed up. So these are the different presentations. It can be generalized. We see some cases, and I'll talk about those in a minute, on the dorsum, or it can have a facial predominant presentation, and also paw pads. It was only a few years ago that Thierry Olivry documented this, that desmoglein 1 in the human literature was only a minor autoallergen in dogs with pemphigus foliaceus. but actually it's desmocollin 1. A desmocollin 1 is found in the very outer layers of the epidermis and stratum corneum, and that's why the pemphigus foliaceus lesions are so superficial. It's different from the human. So desmocollin 1 is the major autoantigen in dogs with pemphigus foliaceus. This is another landmark publication in 2012. It took many, many years of work to document this. So this is superficial pemphigus foliaceus, and there are a number of different subtypes, but they're clinical subtypes. Pemphigus erythematosus is facially oriented superficial pemphigus, and it may have a lichenoid band that makes it look like discoid lupus. Okay, back to the dorsally oriented pemphigus foliaceus lesions. These were found at the site of application of topical medications, and sometimes they would have what's called a drip lesion. They would be more severe where the topical was applied, and they would drip down the sides of the thorax. And I don't know if you had these. This was a case, and we sent a number of these cases to Terry and Petra when they were working this up. Did you have these here? These were pemphigus foliaceus associated with topical flea preparations. And the first one was a Promeris, and both of these, I think this was Certifec, had amitraz in them. And there's another one on the market. I think that was taken off the market too. So, but the interesting thing was, with these pemphigus foliaceus cases, for the most part, if you withdrew the drug and over time the animal would get better and be fine, but not all of them. Some of them had to be treated, long-term with immunosuppressive steroids. Oh, and this is the third drug. I can't remember the name of this one. Okay, so I'm not going to talk, so the point of this photo is showing that it's not just localized to the area of application, that the lesions could be on the foot pads, on the ears, or on the abdomen. And this is a beautiful non-follicular pustule of pemphigus foliaceus. How am I doing on time? Okay, so we're going to talk about, I'm not going to talk about interface patterns here because I have a, go, please.
I'd like to ask you, what's your approach to the post-surgical dermatitis from the histological point of view when you don't get a nice dermatological history? Because you have many different, in Italy we also have leishmania as a different
Right.
So, what do you write? And I personally have history of small pustules, sometimes follicular that respond to the interaction of products, or vice versa, large pustules with many catalytic cells, either like pemphigus, on his spot, and they just go out with the antibiotic treatment.
So this is, so Chiara has asked a question that as a pathologist we deal with every single day, and that is you have an animal with a large crust or pustule, and your job is to decide if this is pemphigus foliaceus, is it dermatophytosis, is it secondary to leishmaniasis. So I'm going to tell you the textbook answer. The textbook answer is there was a 1996 landmark publication by Dr. Goldschmidt. Everybody knows Dr. Goldschmidt, who was in Padova for a year. And to make a histologic diagnosis of pemphigus foliaceus, you need a gigantic pustule that spans multiple adnexal units. The pustule has non-degenerate neutrophils and well-formed acantholytic cells. And the pustule shows waves. Above the pustule, there should be crusts which show waves of pustule formation. That's classic. That's not what we deal with on a daily basis. What happens in some of the pemphigus foliaceus cases is the pustules have ruptured, there's no active acantholysis, and you see these tiny, either oddalized or desiccated acantholytic cells. That's number one. Two, you can have some cases of dermatophytosis in dogs that will form pretty good-looking acantholytic cells. For pemphigus foliaceus, I read the history and see if it matches. I'm on camera. I honestly don't believe the history when they're trying to look at an animal and tell me if it's a follicular or non-follicular pustule. I often can't tell. I struggle with it. If I make a definitive diagnosis, I do. If not, I tell them they have to biopsy the animal again. And and we've had cases that require 3 biopsies to diagnose pemphigus foliaceus. That's what they have to do. Is that what you do? Yeah.
It's difficult to suggest the veterinarian to take the biopsy because they think you're not.
For full disclosure, what I often do is have them send additional crusts, just in formalin, and then I process that at a reduced fee, is what I will do.
I'm sorry.
Yeah.
How many, or I mean, do you do just one single PAS staining, or do you do many recaps for so much time?
So there's another publication that showed, as pathologists, we generally don't miss dermatophytosis in tissue section with acantholytic cells. We generally don't miss it, and that was a publication out of Cornell a few years back. I do 1 PAS stain. I don't generally go, unless I have unless there's folliculitis, and if I have, in the pemphigus foliaceus folliculitis, I want to see the pustules in the external root sheath, not so much in the infundibulum, and then I'm more confident. If it's in the infundibulum, that's hard. Thank you. All right, we're going to move on to, I want to finish by 10:30 and then stretch a little bit, okay? And then, I'm just going to say, we have a whole lecture on lupus. So lupus-specific lesions have to do with necrosis of the basal epithelium and a mild inflammatory infiltrate. So the basal layer must be involved in a diagnosis of lupus. And this is, and you'll see this in the next lecture as well. This is from Bernard Ackerman, Skin 101 website, and this is a patchy vacuolar change in the basal layer with melanophages. The derm term is pigmentary incontinence, right? And so in the next lecture, we're going to go through all of these forms of lupus in dogs. I'm going to skip through it now. And one thing I want to point out for you, those who are studying for the board exam, this manuscript from 2014 is absolutely excellent. This is from Julie Yeager, and she did a tremendous review. It's a long manuscript on comparing erythema multiforme, Stevens-Johnson syndrome, and toxic epidermal necrolysis. And some of the, I'm going the wrong way. Some of the pearls, the take-home message from this manuscript is that erythema multiforme is not like erythema multiforme in humans. It's totally different. Erythema multiforme in humans is a post-herpes virus lesion. Not in dogs, not in cats. And the more severe form of erythema multiforme, the toxic epidermal necrolysis, also called Stevens-Johnson syndrome or erythema multiforme major, that is like the human disease. But as a pathologist, what you need to know is that you can't distinguish these diseases. That's not your job. That's the clinician's job. You're going to give them a diagnosis, and it's their job to determine what spectrum it falls on. And that's due to the amount of mucosal and skin involvement. So you're off the hook. The one thing that's come out in a publication by Thierry Olivry, as well as mentioned in Julie's paper, that the lesions, the cutaneous lesions of the severe form of erythema multiforme, Stevens-Johnson syndrome, toxic epidermal necrolysis, are flat. And that is in sharp contrast to this disease we see in dogs. They don't always have to be old dogs, of this proliferative erythema multiforme. Let's just go back and look at a few. So for our diagnosis of erythema multiforme, we want to see an interface reaction, so a vacuolar change in the basal layer with keratinocyte apoptosis in all layers of the epidermis. And so your correct derm terms here are, these are apoptotic cells that are surrounded by lymphocytes, so it's apoptosis and lymphocyte satellotosis. And this is a dog with a more severe form of erythema multiforme because of the mucosal involvement, gingival involvement, and a widespread involvement of the skin. So that would be a Stevens-Johnson syndrome. All right, everybody still with me? Awake? We need a coffee? All right. Folliculitis. I have some cool stuff to show you here. Hopefully you haven't seen it. This is from a publication we issued a couple years ago. You're going to see these cases. And what this is an acute and severe form of folliculitis. And how it differs from the routine folliculitis, this is in the dog, is hemorrhagic. And is in the superficial to mid-dermis. And the outer root sheaths are necrotic. So you get outer root sheath necrosis, and then this tremendous suppurative inflammation with hemorrhage, forming a hemorrhagic pustule. If you see this pattern, you want to ask about grooming. Do you see this here? You see it, okay. So you ask about grooming. So this is acute follicular rupture with necrosis of the external root sheath. The epidermis is not hyperplastic, and there is hemorrhage, edema, and suppurative inflammation. These dogs are terribly painful. We have had dogs where the lesions were missed because the hair coat is so thick. This often occurs in very thick coated dogs, and some even have been worked up for discospondylitis. They've had myelograms, they've had x-rays, but only when the coat was clipped were the lesions apparent. This dog was owned by a laboratory animal veterinarian in our hospital. He had washed the dogs 2 days prior with some shampoo that he had at home, and this is just the characteristic feature of these acute hemorrhagic papules and pustules. And so this was initially reported in a dermatology meeting by Thelma Lee Gross, and then we followed a number of the cases. And what we found was that grooming products, it could be those coat strippers, you know, the coat strippers, or shampoo, conditioner. Also, we had a case in a what do you call it, a treadmill, water treadmill, and then a contaminated surgical scrub. So it's a wide variety of lesions. So it's this acute severe reaction. And for the most part, when I've seen that degree of follicular rupture acutely, it's pretty correct. I mean, I haven't seen any case caused by another cause except for grooming. Or have you?
I had a couple of cases where grooming was not reported in the history.
Yeah, it's hard to know then.
They were hemorrhagic and
yeah.
And I can't remember what deal was actually.
So the problem is that what you should do is you should culture the shampoo or the brush, but sometimes that it's hard to get a culture from the shampoo because it just doesn't, the bacteria, just the ingredients interfere with the bacterial culture. But you can. Okay, this is something sort of brand new. Okay, I'm going to show you three photos of this. This is a dog, maybe four. Do I have four yet? This is a dog that's presenting with ulcerative dermatitis. On higher magnification, there is folliculitis and furunculosis. But what's different from this, from bacterial typical staph furunculosis, and different from our post-grooming, are these foamy macrophages in the interstitium. It's a little bit different. It's more diffuse, although you do have folliculitis and furunculosis. It's really neat. So this is an external root sheath, and these blue dots are aggregates of rod-shaped bacteria. These bacteria are gram-negative. It's not a good slide, maybe the next one. So this is a Mauldin starry stain, and these are the bacteria either in macrophages or free in the dermis. And these are the same bacteria within an outer root sheath. So this is an emerging pathogen. It's called Burkholderia species. It's in the family of Burkholderia sebaceae. It's a dog disease. We reported one case in our post-grooming furunculosis. Most of these dogs are on cyclosporin for atopic dermatitis. So the difference between this and regular folliculitis and furunculosis is that massive dermal inflammation. The rods can be seen with a Giemsa or with a Mauldin starry. Now, Fran Banovich reported these first 5 cases with cyclosporin administration back in 2015. We have another 8 cases that we're reporting, and not all of them have cyclosporin administration. It's a really something you should look out for. It's a new emerging pathogen. Burkholderia was in the family of Pseudomonas, but the microbiologist renamed it. Our subepidermal vesicular pattern. So a low magnification pattern, there's a clean break between the epidermis and the subtending dermis, and sometimes you'll have little pustules. So in the old textbooks, the differentials would be epitheliogenesis imperfecta, aplasia cutis, bullous pemphigoid, and epidermolysis bullosa. And I'm talking about dogs. Well, dogs and horses, actually. Dogs, horses, and pigs. For the dog, these are the top 3, and the horse are not reasonable differentials. These diseases have been renamed. And so the current nomenclature, there may be even a more current one than this. This was 2014, where they go to this manuscript if you want to place your canine or feline patient into the human nomenclature. So this would be called, this is a family of Labrador retrievers, and they were born with ulcers, and they sloughed their nails, they sloughed their paw pads. This dog, they were kept alive because the owner refused to euthanize, and this dog actually died of a perforated duodenal ulcer. And this is a form of epidermolysis bullosa. This is the dogs as puppies. Acute sloughing, so this would be congenital. This would be a problem in the hemidesmosome or basement membrane zone. So in the dog, for the congenital form of this blistering disease, there are 3 differentials: simplex, junctional, and dystrophic, and depending on where the split is occurring in the basement membrane zone. For acquired disease in the dog, the 2 disorders that are most common are mucous membrane pemphigoid and epidermolysis bullosa acquisita. Bullous pemphigoid is now very rare in the dog. So this is a case of Eurasia dogs that we reported. It was a litter of 6, and I love this photo. It's kind of Art Deco. It's kind of hard to see, but there are big, normal, fat puppies and these little skinny ones in here too. And they were born with also sloughing of the tongue, sloughing of the skin around the prepuce, on the paw pads, and on the vulva. There's a clean slough. This is what you want to look for. This cannot be artifact because the epidermis is adhered on either side. And in these blistering diseases, you will see a clean break between the epidermis and the dermis. And in this case, this is the first time that's been reported. Our problem was we're in the basement membrane zone here, and there's a protein, a huge protein on the basal layer side within the basal keratinocytes called plectin. And I'm just going to skip for a matter of time. Our dogs had really abnormal hemidesmosomes. And Thierry did the plectin immunohistochemistry for us, which made us start looking for the mutation. And this is the oral mucosa of normal dog. This is plectin and is staining normally. And these are our Eurasia dogs, which have patchy to no plectin. And so we were able to find the mutation based on this immunofluorescence. It's just another differential. I'm going to skip through this. So, Leonardo, should we take a 5-minute break? It's 10:30. Let's do that. Is that okay with you? I would like to do that. No, thank you.
What do you have?
I have water. I need nothing, thank you.
Would you like something for a juice? Something? Are you okay? Okay, I'm going to take coffee. I think
Ah, sì, quello sì, però ecco, la casa da un modo diverso, anzi, non era riferito alla considerazione generale. No, perché c'è anch'io che differenza sì, no, ero anch'io questa idea. Sì. Morning.
Good morning.
Nice to meet you. I'm Letizia.
Elizabeth, nice to meet you.
I'm here doing my first year of residency.
Oh, pathology?
Yeah.
Oh, excellent.
I was wondering, what's the program for the day? How are you organizing
yeah,
your
I think-
lectures?
There are 2 more lectures after this. Each
Okay.
lecture is roughly 1 hour. And then this afternoon, we're going to do slides at the microscope.
Okay, at the
And then-
microscope. Okay.
Yeah, and then we're finished at 2.
At 2.
2 o'clock, yeah.
Okay.
That's what I understand.
Very good.
But I guess they did not print up a document.
No, I personally don't have a printout, and I haven't seen it around. So.
That's all I know. So
Okay, that's good
yeah,
information.
yeah.
Thanks a lot.
Watch out for the.
elemento, quindi anche questo Tired? Good.
We're on the webcam.
Ah, yeah, you're welcome.
So I will go until 11 now,
Yeah,
and then take a break. And, then,
okay.
and when do we need to be finished?
You make another break at what time?
At 11? No?
Is 22 years.
Oh no. I'm in at 12.
12. Yeah, yeah. Then we take another coffee and then
Okay.
we'll
And
start.
then we finish. Okay. Is that good?
Yeah, sure.
And
Very
then,
good.
and then we go to the microscope.
Where are you going? We can go also
Train station? Correct, yes. Okay.
and Jimmy is
Probably still sleeping. Can't
yes.
So the point of this section on subepidermal vesicular disease is that if you're examining a biopsy or an autopsy, if you're doing an autopsy and necropsy on a dog, for the congenital disease, it's going to fall into one of the three categories of epidermolysis bullosa, and this depends on where the defect occurs within the basal cell layer or the basement membrane zone. For the acquired, these are you're more likely to see on a punch biopsy, the subepidermal blistering diseases. Your two differentials are you're more likely to see mucous membrane pemphigoid or EBA, as bullous pemphigoid is really not very common. And this was an editorial back in 2014, which discussed that the odds of bullous pemphigoid in the dog were uncommon. And this was a comparative prevalence of canine and human autoimmune blistering diseases. And this is in a total of 77 dogs. 48 of those had mucous membrane pemphigoid, and 26 were epidermolysis bullosa acquisita, which is a type 7 antibody, collagen 7, where only 10 were bullous pemphigoid. So bullous pemphigoid is, while as pathologists, as older pathologists, we would put it in our differentials very commonly, it's not so common anymore. And in fact, the dermatomyositis of the collies and shelties was previously called bullous pemphigoid. In the horse, however, we still see bullous pemphigoid in the horse, and this is a case of a mare with an acute onset of sloughing the haired skin and non-haired skin of the mouth, vulva, and oral cavity. And this was actually the photo I showed you before. This was bullous pemphigoid. So in the horse is still a reasonable differential. For our nodular diffuse pattern, what we need to discuss is the differential for reactive histiocytosis. And what I photographed for you here is a classic presentation of reactive histiocytosis, which is pretty common in my biopsy service. It causes a bottom-heavy cellular infiltrate that tracks along adnexal units into the dermis. The infiltrate is often angiocentric and associated with necrosis. And you should see an admixture of histiocytic cells, small and large lymphocytes, a few neutrophils, but plasma cells are typically rare. This is a classic image of reactive histiocytosis. What has become more difficult in making this diagnosis is inflamed, non-epitheliotropic cutaneous T-cell lymphoma can look exactly the same. The difference is that you tend to get larger round cells in the inflammation, but it's difficult. And not only is it difficult on the histopath, it's also difficult on your ancillary testing. It's difficult when you do, you'll do a CD3 stain on these, but it's still a mixed cell infiltrate. So on some of them, you'll have to do clonality. So what I do now is if I read a biopsy with this pattern, but the cells look more pleomorphic and worrisome to me, I put a comment in my, a comment that says that some of these cases cannot be distinguished from inflamed lymphoma. I have a fly. But I don't want to pursue that, the clonality and immunostaining unless the animal doesn't respond as it should to reactive histiocytosis, because it's all very difficult. And I assume you're seeing those cases here too.
I also have another problem, and I would like to ask you a question. Where do you set the threshold from histiocytic granulomatous dermatitis, and where or when do you start to look for, when you start to do special stains?
Right, so one of the problems, so ideally we should always do special stains on this. That is the answer, right? Yes, you should always do special stains. But where it becomes difficult is when the reactive histiocytosis affects the panicular adipose tissue. The panicular adipose tissue, you get granulomatous inflammation. So then it's very difficult sometimes to know, is this a reactive histiocytic disorder? Is this a sterile granulomatous disease, or is it infectious? And so then you do need to combine the clinical presentation. So reactive histiocytosis, nodular lesions, can be plaques, often on the face, maybe in the nasal plana, maybe on the sclera, versus your infectious disease, and the dog could be anywhere, really. Those are the tricky things. And I do my due diligence and tell them, I do my special stains, I tell them it's negative, that it looks like reactive histiocytosis, but if there is some granulomatous inflammation, I tell them they have to do their job, which is to do culture, aerobic, anaerobic, mycobacterial, fungal. And then this was Peter Moore and Verina's paper showing the non-epitheliotropic lymphoma. The cells do tend to be a little bit bigger. Now, I talked to Verina, and she's had some of these cases that also spontaneously cure. So there is some very sticky, unclear things in the literature about non-epitheliotropic inflamed T-cell lymphoma. For our atrophic pattern, I just want to bring up another differential diagnosis for you. This is a case that came into our hospital. It's a 2.5-year-old miniature dachshund, female spayed, only 2.5 years old, with a 7-month history of progressive hair loss. Everything about her was normal. She didn't have any increased urination or increased hunger or urinating in the house, no problem. And this is her. Let's look at her lesions. Ventrally oriented, complete alopecia with she's a spayed female, so she has a little bit of gynecomastia, I believe, very prominent mammary glands. And her neck, complete alopecia. Now looking at this dog, you could have pattern alopecia, pattern baldness as a differential because it's a dachshund, but for me it's too sharp and it's too complete. It's too severe. And the little black marks here are just where the clinician had marked for biopsy. Now this dog was worked up for Cushing's disease. It had a T4, which was normal, an ACTH stem, which was in reference range, and the CBC chem strain were completely normal. And the histopath is non-inflammatory alopecia. So we had many flame follicles, which these are haired telogen follicles that have excessive tricholinal cornification. And so for a flame follicle, you want the flames to go all the way through the outer root sheath. Otherwise, it's just a telogen follicle. So this is non-inflammatory alopecia. The sebaceous glands are normal. And there's some kenogen, which are hairless telogen follicles, and haired telogen follicles. And a completely normal workup. So what the answer was, the female owner who was an older woman. She was applying topicals prior to bed, and the topical preparation had estradiol, testosterone, and progesterone in it. So we see these cases more and more commonly. So now when I read a non-inflammatory alopecia that looks like alopecia X, right? It looks like alopecia X, but the distribution is wrong. I have to put in these topical creams, which I think are just being prescribed more to older women. And so the owner started applying the medication in the morning instead of in the evening. And I meant to tell you, the dog was sleeping in the bed with the owner, right? So she was applying the medication, the dog sleeping in the bed with her. And she started applying the medication in the morning, and this is a picture of the dog, and it grew its hair back. And this has been reported. I think these cases are much more common than what's in the literature, but so topical estrogen used for postmenopausal symptoms in women. And that's the end of this entry lecture. I think I'm going to do the lupus lecture next, if that's okay. Any questions? Oh, sorry, I'll turn it off. minute. Okay, this is one of my favorite topics on lupus. Everyone's with me? We're all awake after the coffee? So lupus has been is another one of those diseases that has been, we've tried to parallel the human literature in the past, and it hasn't always worked successfully. So lupus is a spectrum of inflammatory disorders, and in that spectrum, you can have animals and humans with lupus-specific skin lesions and non-lupus-specific skin lesions. When we're talking about cutaneous lupus, it is a requirement that the skin lesions are lupus-specific, and that a human with cutaneous lupus can have the lesions with or without signs of systemic lupus. And this was created by, there was another landmark publication in 1997, and it's called the Sontheimer classification for lupus in the human literature. So what are lupus-specific histologic features? This is a, let's see if I can, higher image, which I showed you in the last lecture, is a patchy vacuolar change in the basal layer. One thing that you should really look for is that the keratinocytes in the basal layer will stretch, they'll stretch out, and this is called squamatization. And I think that's a very reliable feature of lupus or any interface disorder. This is showing thickening of the basal lamina, a few lymphocytes, there's a plasma cell or two, and pigmentary incontinence. So this histologic feature tells me that there's been damage to the basal cell layer, and this caused the melanin and the melanocytes to be released into the superficial dermis. So the lupus-specific is a group of features that you have to put together. Hyperkeratosis. Epidermal atrophy is not always there, but when it's there, particularly in the nasal planum of dogs, it's very, very helpful. The basal layer can undergo degeneration. The basement membrane zone will be thickened, and you should have a mild mononuclear infiltrate. So in the classification in lupus, there is an acute cutaneous lupus, and this is often associated with active systemic lupus. Subacute lupus may be associated with mild systemic disease, and it's a photosensitive form of lupus. And chronic lupus, referred to as localized and generalized discoid lupus, typically is not associated with systemic signs. And then there are other forms of lupus which we generally don't recognize in our domestic animals. So this is acute lupus, and subacute lupus showing this butterfly rash that is worsened by solar exposure. And this is discoid lupus. It's a little bit thickening of the skin, and classically these lesions are indurated. So you have a central compression. This is discoid lupus, which has a little bit of epidermal hyperplasia. Sometimes you will get mucin deposition. This is an inflammatory infiltrate. It doesn't have to hug the dermoepidermal junction. It's a little bit up here. This is perivascular. And this is follicular plugging. So you have hair follicle keratosis. Chronic discoid lupus causing depigmentation in a man. And this is chronic discoid lupus. And it's known that if the discoid lupus occurs above and below the neck, it's more likely to be associated with systemic signs. And I'm not going to, the purpose of this slide is if you think you understand cutaneous lupus, you probably don't. Okay, so tonight, to diagnose systemic lupus, there are criteria established by the American College of Rheumatology in which 4 of 11 criteria must be fulfilled, including a positive ANA, and those are typically polyarteritis, glomerulonephritis, and thrombocytopenia are typical things. Lupus is most commonly diagnosed in the dog. Occasionally you see it, a cutaneous lupus in the horse. Most of the characterized disorders are breed-specific. There are rare cases of systemic lupus with skin disease of cats in the veterinary literature, but the histopath is not consistent. So you should take a look at this publication. It's excellent. It just came out a couple months ago, 2018. It's a comprehensive review of cutaneous lupus in dogs. And so in this review, they attempted to classify the lupus in dogs like the Sontheimer classification from 1997. And so, and this goes, there's lupus erythematosus, and with lupus-specific skin diseases, and mainly that's what we're talking about in the dog, and some dogs can have skin lupus, systemic lupus. It generally occurs without skin lesions. Let me go through this a little bit more. So these are our lupus categories in dogs. So the localized nasal discoid lupus, generalized discoid lupus, mucocutaneous lupus, exfoliative lupus, and the vesicular lupus of Shelley's and colleagues. Now this review did not include lupoid onychitis. And it includes a nice table that shows the difference between the forms of lupus. The exfoliative lupus being the disease of the German short-haired pointer, but has been reported in Vizslas. The mucocutaneous lupus, very common in German Shepherd dogs. The nasal lupus in German Shepherds, but it can occur in any dog. And then there was a chronic discoid lupus in a Chinese crested dog. So let's start with the one that we dislike the most, and that is the localized nasal lupus. And it's kind of a disease, you know it when you see it. It causes loss of cobblestone architecture, loss of pigment, ulcers, and crusting. Sometimes it causes atrophy. Sometimes these dogs will bump into furniture and you'll have arterial bleeding. One of the manifestations you see, and I'm not sure exactly what this disease is right now, in the German Shepherd dog is sometimes you see these bilateral alar fold erosions. So this is the problem for us as pathologists. And the literature has some confusing terms. The first term is interface, and that means that the dermoepidermal junction is obscured by a vacuolar change or a lichenoid cellular infiltrate. The problem is that lichenoid has two different definitions depending on which human textbook and which veterinary textbook you read. And the first definition is that it obscures the dermoepidermal junction. In the second definition, it doesn't obscure the dermoepidermal junction. So what we're doing now, and I think it's generally agreed upon, is we use the term lichenoid interface mainly for the nasal planum lesions when we have convincing lesions in the dermoepidermal junction and basal cell layer. So when you get a change in the basal cell layer, you have to be careful because sometimes it can be just a manifestation of edema. You really want to look for some sort of cytotoxic injury. Also with ischemia, long-term ischemia, you can get a basal cell change, a vacuolar change in the basal layer. Our overlapping features in the nasal planum are mucocutaneous pyoderma, which tends to occur on the margin of the nasal planum and the haired skin versus discoid lupus, also versus dermatophytosis, which can affect the nasal planum. And the old literature says that you can tell them apart, but sometimes it's very difficult. You really have to have the clinical presentation. The general features of discoid lupus are loss of cobblestone architecture with depigmentations, erosions, ulcers, crust, and scale. What I look for is epidermal atrophy. And then the true case should have a lymphoplasmacytic lichenoid interface reaction. So this is what usually happens to us as pathologists. We're sitting here, this is under our microscope, and we're deciding, is it lichenoid, is it lichenoid interface, and we don't know what to call it. And it's very, very painful for us, right? Yeah. So we give a morphologic diagnosis and a lengthy comment. The problem is that when you look in the oral cavity, the penis, the vagina, the mucous membrane always reacts with a lichenoid band because there are no hair follicles. So what I do when I want to be comfortable about the diagnosis, I look for atrophy, and I need that clinical presentation in order to put things together. And sometimes as a pathologist, you're not going to be able to make the final diagnosis, but that's okay, because the clinician who's biopsying it may just want to know if it's lymphoma, right? They may not want you to tell them it's discoid lupus because they may already know. It's really a clinical diagnosis. And actually, I used to give this as a evidence of what I couldn't tell if it was discoid lupus or not. The slide's maybe 10 years old. Now I think, yeah, that's discoid lupus. So I've changed a little bit. Okay, so what I do is I train my clinical veterinarians. In general, I don't think they need to biopsy these dogs. They biopsy them if they're severe. They biopsy them if they fail to respond to rational treatment, and they biopsy them to rule out other diseases. In this case, I've seen a number of these where the little German Shepherd dog with these alar fold lesions is often nonspecific on the histopath. This is a dog that absolutely needs to be biopsied. This dog is going to have pemphigus erythematosus. I think that's what it has because the lesion is going up the nasal, the haired skin of the nose. Now you can see that a little bit with discoid lupus, but the presentation shouldn't be this severe. And then our epitheliotropic lymphoma will cause depigmentation and slight swelling of the nose. This whole nose is swollen and depigmented, so that would be another reason that they are biopsying. So I don't know if you see this commonly here, but this is another underreported disease, this arteritis of the St. Bernard, also seen in other big dogs. I don't know if I have a histopath of it. I don't have a histopath. It has this weird change in the dermal blood vessels with mucin accumulation. Okay, so that was nasal discoid lupus. It's a difficult diagnosis to us. I really hate it when I get these biopsies if they're nonspecific because they take a lot of mental energy to look at them, a lot of studying. You can't read them out quickly. You really have to take your time. What's relatively new, a new disease that's been around a long time, is mucocutaneous lupus. And this was a series of cases were just reported in 2015. And this, I could use this as the picture I showed you for the human with discoid lupus. It can be subtle, particularly because this is a mucocutaneous location. You tend to get a tremendous amount of surface-oriented bacterial infection. But you want to see this subtle vacuolar change with apoptotic keratinocytes, and you're probably going to have a lichenoid band. Those are your apoptotic cells. The clinical presentation, the differential is lip fold pyoderma. It's just more severe and ulcerative. Occurs in German Shepherd dogs, also affects the anus and the vulvar area. And this is a little dog that we had in the clinic with mucocutaneous lupus, not a German Shepherd obviously, but unusually severe lesions on the mucocutaneous junction and the prepuce and anus. So the best advice I can give you for this is, you're just gonna, if it's on the anus or the vulva, it's a little bit difficult, it can be easier, but this on the lip fold is often accompanied by pyoderma, so I just proceed cautiously. If I can make a diagnosis, I do. If not, I tell them I think there's lupus in it, but I can't interpret it because there's so much bacterial infection. In terms of other lupus, we can have lupus not just on the neck nasal planum, but it can be more generalized. And from this publication, These dogs do not have signs of systemic lupus. And another thing that has come out in recent years is this drug, hydroxychloroquine. It wasn't used in veterinary medicine for a very, very long time, and it was because there was a paper in the 1970s that showed that the drug was cardiotoxic. And when we went back and looked at those papers, the animals were anesthetized and they were receiving intravenous hydroxychloroquine at very high doses. And they didn't autopsy the dogs. They just saw a change in cardiac output. So now we've been using it again, and quite successfully. This extremely old drug. It was used in the First World War as an anti-malarial drug, and what they noticed is that the people, the soldiers that had lupus, got better. Their lupus got better when they were taking the anti-malarial drug. So we're actually using it quite frequently now. And it's very inexpensive for a dog. Even for a 25-kilogram dog, it's pretty cheap. And this is a paper showing that it was used to treat, I think this was a Chinese crested with a generalized discoid lupus. And I see generalized discoid lupus in my biopsy service. I'm a little more confident now in making the diagnosis now that the paper has come out. And it kind of looks like the human lesions, they can be indurated and hypopigmented with scaling. So now I want to digress a little and talk about systemic lupus in dogs. So the one thing you need to know is, in general, chronic cutaneous lupus does not progress to systemic lupus. It just doesn't do it. And dogs with systemic lupus generally have polyarthritis. And lupus-specific skin lesions are extremely rare. However, dermatologic lesions that are not specific have been reported. And that's made the old literature very muddy, because what they did when they were doing the 4 criteria to fulfill lupus, if the dog had thrombocytopenia, polyarthritis, a positive ANA, and then had skin lesions, it was referred to as cutaneous lupus, but it wasn't. They had pyoderma, they had vasculitis, they had other lesions. So this is a little digression. I love to do history because we don't really review very much of the old history that's not available online now. And this was a 1982 publication on canine systemic lupus. And it is really neat to look at how we've changed. So these were the clinical lesions of systemic lupus. And top left is a dog that has scaling on the muzzle and on the pinna. This is the bridge of the nose, scaling on the ears. It's hard to see it. And then alopecia on the legs. Now, when I look at this together, to me, this looks like dermatomyositis. And this alopecia on the nose, not very specific. We see that every now and then, and often it's idiopathic. Now they publish the clinical pathologic data on the 26 cases of systemic lupus. So students, what do you know about systemic lupus? What are the ANAs? When you have a dog with systemic lupus, your ANA titer is usually like 1,200, 800, 1,200, 1,400. Now we're going to look, it's almost a little hard to read. We're going to look at the, I can see it on mine, but I can't see it. So this is the ANA here, in this column. And the first case of systemic lupus has an ANA of 1 to 10. The second is 1 to 80, 1 to 10, 1 to 40, 1 to 10. Also, you need to look at the breeds. Collie, Sheltie, Collie. It's interesting, right? There's another Sheltie. Now this is the histopath. What I want you to see is this bottom left-hand panel. Now, you third-year residents, you know what this is. This is hepatocutaneous disease, right? You have thickening of the epidermis with parakeratotic hyperkeratosis, basal cell hyperplasia, and a zone of pallor. This is superficial necrolytic dermatitis, hepatocutaneous syndrome. This photo is of a thermal burn. This photo is of a true leukoid reaction with apoptotic cells in the basal layer, and these two may or may not be a lupus-like reaction as well. What happened with lupus is this was the beginning of veterinary dermatology. Nobody had discovered hepatocutaneous disease until like the late 80s or 90s, right? No one had discovered it. So when they're just starting to group diseases, it's where we started. And then these publications were taken into the textbooks, and as someone was rewriting the textbook, they didn't change it, right? They didn't change it. So you cannot diagnose systemic lupus with a ANA of 1 to 40. It just isn't right. So when you're reading your textbooks, sometimes you need to go to the old literature, right? Particularly in terms of lupus. And this is discoid lupus. I love this one. Let me show you. All right, so this is probably true discoid lupus, maybe this one as well. I'm not sure about the paws here. That's just nasal hyperkeratosis. This is a Siberian husky with paw pad hyperkeratosis. That's zinc-responsive dermatosis. So I'm just trying to convey that when you put in your comment to the veterinarian of a lupus-like disease, don't mention systemic lupus. It's extremely rare. Extremely rare. And your cases of cutaneous lupus are not going to progress to systemic lupus. That doesn't mean it can't occur. It can. It's just not the norm in veterinary medicine. But I see it all the time in pathology reports of systemic lupus. Do you see it all the time too? With people wanting animals to be worked up for systemic lupus. Okay, we're going to talk about 3 more disorders here, and then I guess we decide what to do after that. Okay, exfoliative lupus, this is the disease that I'm very familiar with. We have, in the university where I work, it's used, there's a mission to study rare diseases, typically fatal diseases that occur in people, in animals. That is a mission. And these dogs were donated to us, and they were kept in our colony. They were never, for the most part, exposed to solar exposure. This is a young 6-month-old German short-haired pointer that has hair loss, scaling, and actually hyperpigmentation on the muzzle. This is Freckles, and at 9 months of age. And this is what happened to her years later. So her disease progressed from looking relatively mild to having severe depigmentation, hair loss. This is scarring alopecia with scale and some crusting. And when you would let Freckles out of her run, she would be lame. She would lift her legs up. She had a shifting leg lameness, and she typically had this hunched stance as if she was in pain. As the disease progressed, more alopecia. So these are the lesions of exfoliative lupus. It can be, on the male dogs, it always affects the scrotum. It generally starts on the muzzle. It spares the collar area. I don't know why. There's scaling, then erythema, alopecia, which is permanent, along with depigmentation, and the skin can undergo erosion or ulceration. You can get otitis externa, pyoderma, and aquaporitic nodules. And typically, a severely affected dog has a shifting leg lameness, this hunched stance, and a peripheral lymphadenopathy that's mainly plasmacytic. The clinical features are thrombocytopenia and lymphopenia, both very, very mild. Over time, they become hyperproteinemic. They are typically infertile. This is a recessive trait. So we've tried to figure out why they were lame. We've done joint taps, we did a myelogram, I've autopsied the dogs and looked at everything, and I don't know why they're lame. Right now we think it's the skin. It has to do, I don't know, actually. The lymph nodes have reactive hyperplasia with a plasmacytic and plasmacytosis. This is just showing that these occur in the field trial line of German Shepherd, German Shorthair Pointers, and it's recessive. That's enough of the scrotal lesions. And this is how it starts. This is a dog at 12 weeks of age, and this is a true lupus reaction, and your only thing you will see is a subtle vacuolar change and a few apoptotic keratinocytes. But over time, it becomes much more severe, and the epidermis is becoming hyperplastic as a protective response is trying to repair itself. And so these dogs can be recognized on skin biopsy. The histopathologic pattern is it's really pathognomonic. In addition to the interface reaction, you have a lot of pigmentary incontinence and a lot of scaling, and sebaceous glands are very labile. So once you get this interface reaction in the epidermis, you're going to lose your sebaceous glands. For those of you who are reading biopsies and you're unsure if something is true interface, look for sebaceous gland loss, and it'll make you feel more confident. You have to be careful not to confuse German short-hair pointer lupus with erythema multiforme. It can look identical because you can have individually apoptotic cells in the upper layers of the epidermis. And your history should help you with that. Most of these dogs are euthanized. There is some spectrum in the severity. You can manage them for some period of time with immunosuppressive medication. We had some success with hydroxychloroquine. Cyclosporin doesn't work. TNF-alpha antagonists don't work. And so if there is a form of systemic lupus, these dogs are ANA negative, but we haven't tested them for the other cellular antibodies. But if there is a form of systemic lupus, this is similar, right? And finally, vesicular lupus of Collies in Shelties. I don't have much to say about this. This was termed ulcerative dermatosis, similar to dermatomyositis, but it is an adult onset lesion that causes serpiginous ulcers and erosions on the abdomen. And it's much more vesicular. It means that the lesions are more likely to cleft than exfoliative lupus. Recent publication from 2017 shows that calcineurin inhibitors, this is cyclosporin and topical tacrolimus, can be effective therapies to manage this disease. And the final disease is lupoid onychitis, and we had a big discussion about this last week because I was putting on the SHEFAC workshop for DermPath. With the lupoid onychitis, this is the clinical presentation is nail loss, and you have brittle, soft nails that slough. Histologically, from an affected nail bed epithelium, there is dermoepidermal clefting. There can be a mild inflammatory infiltrate with few apoptotic keratinocytes. You have to have a section of P3 to make this diagnosis. So the take-home message is that generally, dermatologists do not biopsy these lesions for a number of reasons. One is it requires amputation or a portion of P3. And the clinical presentation is so characteristic, generally all the nails are involved, that they can treat them based on the clinical presentation. So a differential would be dermatophytosis, but it generally doesn't affect all the nails. I think your leishmaniosis cases can do this too, right? But they don't have any other skin lesions. It's just the nails. One thing that's happened to me is I've had clinicians biopsy the dew claw. They'll amputate the dew claw, and they don't really notice that it was normal clinically. And so that's really bad. You amputate the dew claw, and it's not diagnostic. So you don't need histopathology to diagnose it. I urge you, if you do read, if you are receiving a biopsy for a lupoid onychitis, put a PAS stain on this because you cannot see dermatophytes in the stratum cornea. They're just really, really difficult at the nail. And that is my routine thing. I take a look, I'm looking for this subtle interface reaction, and I do a PAS. This is to remind you that you can have lupoid-like drug eruptions, and this was a case of mine in an adult mastiff-type dog that was due to TMS. So I'm trying to put himself up. So that's it on lupus. Do you have any questions? All right. What do you want to do, Leonardo, now?
What do you think? Is that we go upstairs to microscope?
Yeah,
Practice?
that sounds great. Yeah.
Yeah?
Yeah, sure.
This time we can have a break of 10-15
Okay, perfect. Yep, great.
Quindi se qualcuno di voi abbiamo 10 postazioni al microscopio sullo schermo, quindi se la parte diciamo la parte del laboratorio continua sotto al microscopio testare, abbiamo la parte pratica, quindi ci illustrerà dei casi sia dal punto di vista clinico che dal punto di vista dermatologico, in cui abbiamo la possibilità, se qualcuno di voi vuole venire interessato, magari gli altri liberamente abbiamo sullo schermo ogni istruzione. Yeah, we are still connected, I suppose, yes. We continue with the practical part and we disconnect the streaming. I would like again thank you very much to Professor Elizabeth Mauldin, and thank you very much to Charles Lewis Davis Foundation, to Dr. Bruce Williams, and to all of you in streaming with us. Thank you, and see you soon. 5 of July, we have a meeting with Eric Lombardini, Dr. Eric Lombardini, about fish pathology, and I would like to invite all of you to participate. Have a nice day. Bye.